Indigenous people, the traditional owners of the land on which we work, and pay our respects to elders past and present. An overview of what I'll be discussing today, a little bit of background about the Centre for Community Child Health, which some of you might know about, our hearing research through our hearing screening program, a big program called Generation Victoria, and then I'll be talking about our deafness registry as an example of what we do. And at the very last, just a little bit of information about our life course platform. So we're just talking about Melbourne. These are the pictures you kind of get associated with in terms of Melbourne, which is right down the bottom, south in Australia, home to the Australian Open, as you can see, and lots of wineries as well. And, you know, our streetcar, we call it the tram. But there are some differences as well. Like, very funnily, you talked about the weather. I kind of Googled, you know, differences and similarities between Canada and Australia. This came up, but Melbourne's actually known for its 4 seasons in one day, not over the year. And when I looked at the map, we're actually kind of almost the same size, a little bit smaller than Canada, and, you know, population-wise, I guess a little bit smaller. We also have Medicare in terms of delivering health services, and we do have a mixture of private and public. We have Tim Tams, whether you got Tim Hortons, and something that I have to remind myself is to drive on the wrong side of the road. And here, this is where I come from, the Melbourne Children's Campus. This is the Royal Children's Hospital. We do have a very interesting interior in that we've got a caterpillar, an aquarium, and also meerkats, which is manned by zookeepers. And we also have a wonderful park outside. At the Centre for Community Child Health, our purpose is to see every child thrive. And how we do this is to try and achieve equitable real-life improvements in children's health, development, and well-being within a generation. And in achieving this mission, we want to see children and families feel valued, heard, and their needs are met, communities supporting every child, high-quality services for children and families wherever they live when they need them, and a system that promotes the best conditions for children to live, learn, and grow. So our priority areas are health development, mental health, connected parents, thriving communities, education, health and social care working together, and equitable services. And our values are impact, evidence, equity, partnerships, prevention, and learning. So this would not be a very familiar, I think, diagram or figure that many people have seen. With the reality being on the left and what we want to achieve with equity on the right, so that everyone gets the supports that they need. So I'm going to talk a little bit about our Universal Newborn Hearing Screening Program, which is actually home to the Centre for Community Child Health and was kind of set up about 20 years ago. And nowadays we screen more than 99% of the 78,000 births per year in our state. That's over 70 different maternity hospitals, both public and private. So all the staff come from our centre, and we screen about 210 infants screened every day. The advantage of that is that we actually have, I guess, contact with almost every single newborn baby in the state when they're born. So as part of this service, we set up a registry called the Victorian Childhood Hearing Longitudinal Data Bank about 12 years ago, really trying to capture outcomes of newborn hearing screening. And how we've set it up is so that parents can give consent to their clinical data that's already collected to be shared with the data bank, and also with consent about data linkage and also use of biological samples, so that we can use all that information together for better personalized prediction in the long run. So how we do this is through the recruitment through the screening program, but also through our clinical services. When children come to our clinical service, families are invited to fill in a questionnaire that they give consent to both the clinic and the research data bank to share the information. And over time, I know that you also use Epic, but we've been able to put this into our Epic portal, the patient portal, where when they come into the hospital, if they are able to get onto the portal, they fill in these questions through the portal. and that gets transferred into our clinical, I guess, information when we see the family, and that gets transferred into our notes, which means that the clinician benefits from this, from having all that information in front of them, and also families are likely to say, oh, well, yes, happy to share this information, and that information can be extracted and go straight into the database, which is a REDCap platform. So through the 10 years of this research platform, we've invited more than 2,500 families and have about 51% participating, which is from the newborn hearing screening program, which, I think is actually quite a good capture for a population-based database. And most parents give optional consents, and most parents are happy for data linkage, for maternal serum access, newborn screening count access, recontacting for future research. For example, we've got new research programs, we can invite these families later on. And to, I think, capture these participants in kind of the long run, we held, for example, a family day this year for World Hearing Day, where we invited all these participants to come back and hear about what they have contributed towards in terms of the data they have shared. And we also celebrated the Victoria Hearing Screening Program turning 20 years this year. So in terms of this particular data bank, we've been able to answer about 50 research questions, and also support lots of researchers and students in in training them up in terms of research. And some of the other impacts are used this platform to recruit for children to look at genomic testing for deafness, and we were able to use this information for funding. So we were able to pitch to Medicare, and they've now made this Medicare item number for exome sequencing for all these families. And this was on the basis of Dr. Leong Downey's study, where we were offering this exome sequencing for these children. And we also did a cost analysis, and that was, evidence we used for translation. The other main impact was on translating this into targeted screening for a virus that causes hearing loss called CMV, because picking it up early can prevent the impacts on children's health and development. And these were just some of the research studies that we used to work this piece of work. And we are also part of the National Registry, where we're trying to track long-term outcomes of this congenital CMV infection. So coming back to the Generation Victoria study. So this is a huge study that has been happening from 2021 to 2023. And these are the four kind of main leaders. Some of you will have met Professor Shank Goldfeld, and Melissa Wake, who is one of my mentors and supervisors. And this is a statewide cohort that's open to all babies born between those 2 years in Victoria. And the 5 building blocks is a consented cohort where, all babies who are born, their families are, invited to be part of the study, where they consent to be part of the study. Biosamples, which means that we can access samples like the antenatal samples that the pregnant moms had during their standard antenatal care. Linked administrative and services data, so a lot of work doing in linking other data sets together. There's also a block of collecting specific data that's through an app, and also integrated studies in terms of other researchers making use of this platform for either, trial research or registry research. So, this has been set up, I guess, as a research platform, as a service rather than research. So as I said, it's a very large cohort. It's Australia's largest, most comprehensive parent and child longitudinal cohort. It has more than 1,220 participants, with over 26 participants from regional areas, more than 900 parents who are First Nations, more than 72 languages, and also participants from disadvantaged areas as well. And this is kind of how it's been set up. So the brackets in yellow are the things that have already happened. So for these 2 years, we've already collected biosamples and bloods. We've also collected newborn blood spots, consent from families, saliva from parents and families, and also infant stool and breast milk. And then there's more work and funding that we're trying to get in terms of more waves of collection in terms of as these children move to school age. And you can see that the pink are the Gen V specific collected data, and then the rest, the data is already being collected elsewhere. So the work that's being done at the moment is trying to connect all these databases together. So as I said, it's a statewide cohort added with national data assets, which can become a very powerful research platform for discovery and intervention that's low burden to participants, and you can build once and use many times. And these are the different kinds of data sets that Jitendra Mohar, who's the Gen V data lead, is looking at. There's curated administrative data sets, which are either state or federal based. There's services and programs, including a maternal and child health platform that all babies have access to. Imaging, specific survey data through an app, geospatial data, and then there are many different registries and cohorts that you'll hear about later on in this talk that is also running in parallel. And the idea for the future is also to include owners as well. And how are people using Gen V? So lots of different collaborators. There's already 12 collaborators using these studies. And also other, lots of funding that's gone in, lots of people kind of wanting to use this platform to do other types of research. So I'm going to skip back and going back to our hearing research. So right now what we're trying to do is utilizing our existing child deafness cohorts and also piggybacking on the Gen V methodology to, I guess, create something that is more sustainable, because with our Vic Child program, we've realized it's such a lot of money to use over time to be able to go out to families to collect that data. So isn't it much better to be able to join the data that's already collected so that we don't have to use that resource and that time and effort and money? So now our strategy really is to enable using existing research, clinical and administrative data sets and utilizing Gen V's expertise to create enduring linked data sets with this Australian National Child Hearing Health Outcomes Registry, which I'll talk about in a minute, as the centre. And you can see all these different research and clinical cohorts and data sets that are already existing, linking them together so that we can have the appropriate data to look towards better prevention, to reduce hearing loss progression, better diagnosis with precision medicine, and better management to look at, the effectiveness of screening and interventions. So here I'm just going to spend a little bit of time talking about Anchor, which is looking at connecting and utilizing data for equitable care and outcomes for deaf and hard of hearing children. Why did we set this up? Australia's got really well-developed hearing health systems. So we all run, each individual system works very, very well. But none of us are joined together. So when a family goes through the system, they go through a screening, but there's a bit of a gap in terms of getting to diagnostic. And then there's a gap in terms of getting to early intervention services, and another gap going to hearing clinical services. So if we can kind of join these dots together, and as you can see, it all kind of works in a cogwheel, but if we can just join them better, then we can connect that data that remains unused and connect them up. We also know that despite really early diagnosis nowadays, with newborns being diagnosed with hearing loss within the first few weeks of birth, they actually have access to all these services, but not all children are actually reaching their best developmental learning and health potentials. And in fact, children who are deaf and hard of hearing still lag behind at least one full standard deviation in their language measures by the time they get to school as compared to hearing children. So perhaps the reason for this could be that they're not accessing the services the right way, and there might be inequities in accessing services. So we hope that this could become a national reporting for outcomes and evidence base for child hearing health policies. We hope this can improve service delivery and equity of access. And also in the future, when we are able to get a consented cohort, use it as a population-based research data platform. And this has been funded by our NHMRC, which is by our Australian government, for 3 years. So our vision is really to give all deaf and hard of hearing children the best opportunities to reach their full potentials. And we do this by connecting and utilising information to provide research and optimise service delivery. Before we even kind of go into our methodology, the first biggest thing we have had to do is actually connections with the relevant stakeholders. And that's been probably a whole years of work in terms of reaching out to the community, reaching out to the right people, getting people on board. Because if you don't get people on board at the start, then things are not going to really work going forward. So we really wanted to involve them at the very start with co-designing this whole process and having everyone together on the journey. And as you can see, there's many different groups of people involved, and that also includes parents, the Aboriginal Torres Strait Islander peoples, and also the deaf community who have very different cultural beliefs. And in doing this, we set up a group called the Auschchild Deafness CAG, or the Community Advisory Group. This is a group of parents who are now working with us to exchange advice, and they get trained up in terms of what research means to them, so that they can also help us with our co-design and our efforts. And we also have a budget to reimburse them for their efforts and provide them with training. So these are some of the parents that have been recruited. We had 4 core parents who started this group out, and the 4 of them really took charge of recruiting more parents. So we gave them really the onerous to do all that, so that they own the whole group and they drive the whole group. And ongoing, we've actually got a philanthropic organisation to support them in the ongoing after our grant finishes. So coming back to the aims of this program, so the first thing we wanted to do was really to determine what's out there. So we need to just work out, in the whole of Australia, as you know, it's quite big, as is Canada. We just need to work out what's existing, what are the databases, what are people already collecting, what services do they provide. The second aim is to just pick 2 states. So being so big, it's probably impossible to do it all at once. So we picked Victoria and Queensland, Queensland being on the north and Victoria being in the south. And picking these 2 because we already have collaborations with that state, and also we have the best and richest data banks already. So we had VicChild in Victoria, and Queensland also has a database similar to us. So we want to see whether those 2 databases can join up all the rest of the systems, and if we can demonstrate this as a prototype, then it can be used for a national extension. The third big piece of work is actually to develop a core outcome set, because there's no point asking people to measure things when they don't want to measure it. So this piece of work has been going out to many different, children, family services to work out, well, what is the best thing we want to do in terms of measuring in the long run. The fourth is a cost benefit, so that we can provide like a business case going forward to the government, so that hopefully the government can fund this on an ongoing basis. And if we can connect the dots and connect some of the data sets, then we can answer some key research questions. So going back to aim 1 in terms of how we're identifying these, we're really doing this as a snowballing survey type thing. So we're really just reaching out to our existing contacts and then really sending them that survey off in the snowball effect. And we're trying to reach all of these different services out there. And we're kind of slowly getting through, and we've had representatives from every state so far, which has been really good to see. Obviously more from Victoria and Queensland where we're based, but also, Northern Territory has been quite isolated. We've still got someone there filling out our survey, which is great. And we also have all different services also participating. With myself having the medical kind of services links, we're kind of on the top of the medal tally. and diagnostic audiology, but everyone else is kind of also participating. In terms of how we're going to join the data sets together in the two states, the things that we've been working through is establishing a working group and looking through consent processes, identifiers, and identifying common data models, and hopefully creating some mechanisms for enduring combined data sets and linkage. So these are kind of some of the existing databases that we already have. So it's a little bit complex of a diagram, but on the right-hand side are all the different domains that may exist. So, for example, hearing characteristics, child development, education, information on hearing devices, medical information, information on child communication, quality of life, and supports and services. And then going from the left, on the left-hand side, down that column are all the different services. So I think with child deafness, it's a great condition to choose because these children do go through a very confined and limited number of services. So they go through screening and then diagnostics. They go through rehabilitation, which means they're getting hearing aids, cochlear implants. They get supported by parent support and family mentoring. Then they go through early intervention services. Then they go to school. And in Australia, we have a National Disability Insurance Scheme that has some data on providing funding for these children. All our children go through maternal child health nurse checks over the 3 years of their first 3 years of their life. And we also have lots of work going on with First Nations ear and hearing check. And also the 3 different cohorts that are already existing. I've already talked about Generation Victoria and VicChild, and also in Queensland there's the Healthy Hearing Program. And we're working through the 5 safe principles for data governance, linkage, and release. So that means safe people, appropriately authorized data users only using it, safe projects using the data appropriately, safe settings, making sure there's secure access environments, safe data having protections applied, such as the identification and separation principle, and safe outputs, so making sure there's no disclosure risk. You don't really need to kind of look into the details of it, but just to represent that we do have priority 1 and priority 2 data sets that we're working through, so that's not just kind of manageable in steps. So the databases that we know can connect easily are in the priority 1 data sets, and that's for Victoria on the left and then Queensland on the right. And then that would join together using a government agency called AIHW, or the Australian Institute of Health and Welfare, which uses the SHORE platform, which is like a platform where it's pretty secure. And also in each state, we have data linkage organizations that can do the linkage for us. So the first stage of what we're hoping to do is an anonymized repository, because the data that we have obviously will not have the appropriate consent in place. And we hope that if we can do that and demonstrate that, then moving forward, we can start to ask services to collect the right consent so that information can come in as consented data so that it can become a consented data bank. Going to the third aim, which is developing this core outcome set. So as we know, a core outcome set is an agreed minimum set of outcomes that are relevant to these children and young people who are deaf and hard of hearing that we want to measure and report for research and clinical purposes. And we really want to do that so that we can improve the quality of information collected, because no one is actually collecting the same information at the moment, so that we can inform progress and also help people make the right choices. So the first piece of work in this is to identify the important outcomes. And with this, we're running lots of focus groups and interviews. We're doing a literature review, and we're also partnering with a study in the UK called Poncho, where they're using a COSMAT methodology, looking at a core outcome set for child deafness. Then we're going to have a big list of outcomes, and then we'll have to rank the outcomes. And then after that, we'll have to come together to work it all out, which is probably going to be the hardest. So what we've done so far is, as I said, a systematic review, as well as kind of using qualitative research methods, going to hearing stakeholders, parents and carers, young people, as well as the deaf community. And to be able to be inclusive of the deaf community, we've been giving them the work. So we've partnered with some deaf organizations, and they're actually leading the piece of work, and they have deaf researchers who are doing it. And hopefully we'll come away with many outcomes, and then ask people to rank them through eDelphies and through our consensus meetings. And hopefully we will, at the end, have what we call like an onion layer of different core outcome domains. So hopefully we'll have a core national minimum outcome domain set, then some minimum domains that are specific for specific circumstances. Then we might have some optional outcomes that are important, and also some outcomes where we need further research and when they're not available at the moment. And then going to the fourth aim, really simply, it's a health economic analysis of looking at the costs of data collection, future costs of if we change systems, if we change behavior, and support different services in collecting these different outcomes, how much is that going to cost us? And is it going to, cost in terms of changing databases, etc. And some of the key research questions that we've wanting to answer for a long time, for example, with mild and unilateral hearing loss, nowadays our technology is picking all these children up, but we actually don't know whether hearing aids help them, for example. So, and it's not possible now to do a randomized control trial because most parents don't want to be randomized. So we really need big data to be able to work out the effectiveness of, for example, hearing aids for mild and unilateral hearing loss. The other question we wanted really to answer was there's a lot of haphazard, screening at many different time points after birth in terms of hearing screening in later childhood, and nobody actually really has the evidence, so we're hoping that this data can inform that. So going back to using this for our vision to optimize management, prognosis, diagnosis, and prevention of hearing loss for these Australian children, we've got the 4 streams of work with the National Registry being the glue. Lots of work we're doing with CME screening and data from that, and then deafness genomics with data from that, and also with the GenV platform, we have clinical data sets from special care nurseries where we can merge the clinical data set with our hearing data sets to look at ways to prevent hearing loss in premature and sick newborns. So that's kind of, just summing up the big piece of work that we're doing in our hearing research space. I'm going to talk just quickly in the last few minutes about Live Course. So Live Course is a initiative from the Murdoch Children's Research Institute, of which Centre for Prenatal Health is part of. So the whole idea is having data for open science. And we have more than 40 long-term cohort studies within Live Course that are all led from the MCRI. And these, if you go onto this website, you can see them. They are all data available for external researchers to use. And it's kind of, data for open science. So if you're interested, you can check out that website. And this is kind of part of the website where it's kind of, trying to give our data for others to use for answering, important research questions. So I finished quite early, so I have plenty of time for discussions. Just want to thank my immediate research team. This is my hearing research team. Lots of people involved in the ANCHOR program, which is a national program. We have lots of partners while we're doing this work, and lots of funders as well. And I just want to thank you for having me. Thank you. Thank you.
Thank you very much. Sure there'll be lots of good discussion. Start with Brian. At the very end, in your final slide, you talked about the open science sharing initiative that you have. How is that governed and how do you decide what is a worthwhile research question that deserves to get data?
Yeah, so there is a data management process. So there's a request. If you go on the website, there is a research lead for this program, which I'm not part of. But there is, if you look at some life course data and access, if you click on that button, it actually has a lot of information on how you can request data. So that information goes via REDCap to the data custodians, as well as the lead for life course, and it gets considered. So each program will consider, well, is this something that we can, let you use? And then each different cohort will have its own, I guess, guidelines on, costs, mainly costs for, data access. So, having someone to actually get the data out for them. So that's kind of in general how it works. Yeah.
Have you considered doing that? I don't know, like a James Lind Alliance
Yes.
right now, and putting in front of all the parents and families what you're collecting and then what questions they would like?
We didn't have enough money to do that because they cost quite a lot, and we didn't have that in our budget. So we're trying kind of to do kind of something similar, but not quite as professional as the James Lind Alliance. But yeah, we are kind of in terms of those outcomes, when we come together with workshops next March, we've actually got a conference where we're inviting everyone to come along. In that conference, we're going to be, this is still a work in progress, having some breakout kind of areas for different groups to work through to rank the outcomes, and then another consensus meeting that will be chaired by someone external to the research group. And we've got someone who's in ethics space who's really good at that. So we kind of got that in the making, but not quite as professional as the James Lind. But if we had enough money, we would do that.
Maybe I'll ask just a follow-up to that. There's an interesting bit about the deaf community, which correct me if I'm wrong, because my understanding is mainly from watching films, Coda, Sound of Metal, fantastic films, around tension within the community, around actually prioritizing how important treatment is for the deaf community. And I wondered if you can comment a little about that in your prioritization exercises with with
so it's going to be a huge learning curve. I think for this year, I think the thing that we learned the most is actually engaging with them, because before that I really didn't have much connections with them. I only kind of know what the organizations are, and with time, I mean, their vision for their community is similar in that they want the best outcomes for their children and they want stuff that is relevant measured. So that's why they came on board. But in that process, we found actually a researcher who's her specialty is actually in engagement with priority groups or marginalized groups, and she has some very, very close connections with the deaf community who have very different cultural values. Obviously, they don't believe. I mean, hearing health is already a term that doesn't go down well, because this grant was from the government and it was called Targeted Call for Hearing Health Services. So, the government call already is not, within their cultural norms. So I think there are people in there that luckily were able to overcome that kind of barrier and kind of focus on, well, we just want, everyone to measure something that we want. So that's how I've kind of gone on to engage with them. And, throughout time, we've realized actually we can't have them in the same room. So for example, for that meeting in March, it's not safe for them to be in a room with hearing people. So we have to do those workshops separately, and they'll have to do that as a separate space, not in the same conference, because the conference actually is a hearing conference. So they don't want to be, amongst audiologists or ENT surgeons. And, we have to have a scaling system so that, their outcomes are going to be in there and not blanketed out by the majority. And the same with Aboriginal Torres Strait Islander children and families. With our First Nations people, we have special ways, I guess, of engaging with them. So we have Aboriginal researchers going out to communities doing yarns. So they call it yarning rather than focus groups. where they kind of sit together and talk. And, you know, we already know that they probably would not want rankings. That's not in their culture. So their outcomes will come out in a different way. So it's actually quite a complex piece of work, which, you know, when I first wrote the graph, now I've realized, oh my gosh, it's huge, much huger than I could afford actually for many parts of it. Yeah.
Thank you. Catherine?
Hi, Catherine Birkin. I've been watching Generation V unfold, and congratulations to you and the team for incredible, ambitious.
Very ambitious.
Yeah.
Like me, but
Overwhelmingly ambitious project. I was reflecting during your presentation how much process work there is going into setting up these networks and doing all the important engagement work. And I wondered how you've been able to share that sort of process knowledge, like locally, nationally, or internationally through publications. Like, has that been a struggle trying to find journals that would publish this work and give these strategies or advice?
I can talk about my own work first, maybe. So I am part of the Australasian Newborn Hearing Screening Committee. So that already sets me up with all the links to all the national, hearing screening networks. I'm also, I chair it's called a CHES, so Childhood Hearing Australasian Medical Professionals Network. So I chair that already with clinicians around the country. So I've got already 2 national workbooks to start off with. And then luckily Hearing Australia is a national provider of hearing aids. So they already have a national database, except that getting data out of them is very, very hard because they are government kind of database, so they don't like people to use it. So I already have those, I think, existing connections to start. So doing this hearing and deafness platform was not, I guess, a crazy thing. It was kind of an achievable thing to start. Gen V, I know, took 10 years to at least kind of plan in the making. I haven't been part of that group kind of setting all up, but I know that, you know, it's a lot of engagement with the government. But even when it started, I think the recruitment is probably much lower than what they dreamed of it being. I think it's about 30% uptake in terms of recruitment. And then of the 30% going forward with an application called Gen V and Me, which is collecting the data, that has only been about 20 to 30%. So what they're really hoping for now is the data linkages being able to work, because without that, they're not going to be able to get the, outcomes that they want. For example, for me as a researcher, I've partnered with Gen V for my CMV work. So what I've done is I've got a grant where we're analysing the saliva samples collected from Gen V, so the 36,000 infant saliva samples, all taken within 3 weeks of birth. We're now processing that to look for CMV, and we're looking at prevalence of CMV. But one of the research questions wanted was outcomes. So asymptomatic versus symptomatic CMV and outcomes. And right now, I think we don't have enough power to look at that because the recruitment, the outcomes rate is so low. So we're really trying to look at data linkage. Hopefully we can get maternal child health data together, because maternal child health nurses in our state, at least, they collect very regular unified data on development. So that's kind of what we're, hoping for as an outcome. And also the Gen V kind of program is trying to get more money from grants for a school wave entry. So I don't know whether you know about the checkpoint or heard about checkpoint. So that was the LSAC, so longitudinal outcomes of Australian children. And they had a checkpoint study when they turned 11, the children, and that was really successful. So I think Melissa Waite is trying to kind of turn Gen V into another child checkpoint at school entry to collect a big data wave collection to improve that input. So it's not easy. Yeah, and there's still lots of barriers in terms of the data linkage because of all the different governance requirements. So from my understanding, it's been very slow in terms of getting that done.
I guess I think we often like to document our successes in research.
Yeah,
We don't tend to document the challenges, I think,
Yeah.
and I'm thinking, and then others don't learn, I'm speaking about myself as well. So
yeah.
I think thinking about where we could publish some process evaluation of these efforts, I think would be.
Yeah.
Excellent.
I'm actually trying to, right now, actually tomorrow, we're supposed to put it in as a paper for the anchor kind of program, because I'm thinking, well, if I fail at the end, at least I've got a paper here to demonstrate what I've tried to do.
Right.
So it's out there, yeah.
You. I'm very
Can you
intrigued.
introduce yourself? Sorry, sorry.
It's,
I like what Catherine did.
Neonatologist. You know, this is new to me, but you mentioned briefly that in evaluating interventions, clinical trial is not a very feasible approach. Did I get that right? And can you speak a little bit on how you're going to evaluate?
Yeah, so with our big child study, going back to, I guess, our experience with having a consented database where we can just send out, when we have a new research study, we just send it out and prove. So it is actually really effective. We've had lots of different researchers approach using our data bank as a recruitment platform. We've got 1,200 children. So for example, recently we're looking at children with the OTOF mutation for auditory neuropathy because of gene therapy being available. We're trying to do a natural history study. So it's a pretty rare gene. And, out of 1,000 on the database, there were 80 that were, at least that we could approach. And that was quite successful in kind of recruiting that way. And what I was mentioning about the intervention was on mild hearing loss. So several years ago, we did a randomized controlled trial where we gave parents the option of being randomized into either hearing aid or no hearing aid for mild hearing loss. No one wanted to be part of that. And we did a lot of qualitative research on that. And it was because they didn't want to be randomized. They lost control. They all wanted the hearing aid because if it's there, why won't we want that? So there are some interventions where we can't do randomized trials and where big data is required to answer the research question. That was where I was coming from. And I know that with Gen V, they have been trying to set that up as well in terms of trials. I'm not sure how successful that's been. We've definitely had registries kind of partnering with Gen V where, for example, with our Vic Child cohort, we're inviting kind of, Gen V babies and babies Gen V inviting us so that we have both data banks, kind of, have families in both data banks so that reduces, burden going forward. So I think having a consented database will work, but of course, an anonymized database, you can't. Yeah. And then, main thing is, when you ask parents for consent, you kind of have that option about being recontacted for future research. Yeah.
You can introduce yourself.
Brian Feldman, I'm a rheumatologist, and so the core outcome work that you're doing is the kind of stuff very familiar to me. I was looking at and thinking about this when you showed the kind of matrix of your different registries and the types of data available, and quality of life and well-being is poorly represented amongst most of the data sources. Is there a reason for that, do you think? Is this not sought?
Yeah, it's mainly from the research studies. Like all our researchers have been collecting some kind of quality of life data. So the NDIS is the National Disability Insurance Scheme. So they're the national provider of funding. So they do, from my understanding, collect some quality of life information. Our maternal child health nurses also do. And then the other three are the research, and some early intervention studies do that as well, but not all. So it's mainly the research cohorts.
Right. Is there a reason why that's not thought to be important to the data?
The services, I guess it's not they don't think about that. They all think about what they do rather than what the outcome could be. And that's why we're kind of trying to change. And I mean, after this work has finished, I'm actually writing another grant right now. And, it needs to be another grant to look at implementation because it's a huge piece of work to work out actually what are the measures that, one language measure can have like 20 different measures. So there needs to be PhD students hopefully kind of working on that for each measure, and also implementation. So how do you do behavior change and, get services to change how they work? How to ask them to collect the right information when people come into the service.
Patrice?
I thank you for the work. Petrus Petrimano, I'm a scientist here and a health economist. And you mentioned that there's a cost-benefit analysis somewhere in there, and I'm curious if you have any more information as to how long-term outcomes, usually long-term outcomes are required in this kind of cost-benefit analysis, are captured and kind of connected to Brian's point before. Like usually quality of life is one of the important components in that kind of analysis. I was just curious to hear your thoughts as to.
Yeah, I mean, I'm not a health economist.
Yeah.
I give all the work to the health economists to do. However, the main data that we're collecting is those main ones like, I guess, cost to changes to data collection, future costs in terms of, so the stuff that we're asking at the moment from service providers are who is actually doing the data collection, what kind of salary, and then what kind of database you have, how much does it cost to run, how much does it cost to change. And the rest, I think, are modeled from an existing piece of work that's already been done from, there's already one publication on the economic analysis of universal newborn hearing screening. So I think they're basing their work on that paper and adding this to that. I think that's how it's being done. But I can provide you more information. I have something written in a bit more detail. I can send it to you if you're interested.
So just for me, some nice learnings. There's a lot of parallels, I think, in our systems in terms of trying to get together lots of different disparate data elements together to link them together to understand important population and clinical health questions. The inside baseball, or I think you'd call it inside Australian rules football, of how you deal with federated models of data in a country with decentralized delivery is very, very similar to some of the challenges we have here. I was actually pretty impressed that you can actually combine two states' data. We can't even combine two provinces in any meaningful way in this country.
Well, I haven't done it yet.
But if you could do it, and also these notions of how to build these giant cohorts that are really, really impactful and have impact on researchers of all sorts of different content areas is obviously the focus of your work on hearing and but lots of other applications from Gen V and all the other work that you've presented. So there's lots of collaborations going on between our two hospitals, and it was really nice to see this laid out so clearly today for us to chew on. So thank you very much, Dr. Sung, for an outstanding presentation. Perfect, thank you.
Yeah, sure.